So I think we can start after this nice reunion of friends. So welcome everyone to this webinar held by the Fujita Bantanei Alumni Association. First of all, I want to thank, of course, Professor Kato for always being here supporting us. And I want to immediately thank my co-moderator, who is, as usual, Professor Isshu Bishnoi. Thank you and welcome. Today we have two speakers, Professor Takashi Sugawara from Japan and Professor 𝒍𝒆𝒔𝒊𝒂𝒂 from India. They will talk about very interesting topics. And the discussion will be helped also by our discussants, Dr. Harikiran, Atiq Islam, and Afzal Sharaf. And we have the pleasure, as usual, to have a commentator, special commentator, Professor Ashish Kumar. Hello, Ashish, welcome.
Thanks, Alberto.
Thanks. We can, I think, start maybe with a few words by you, Professor Kato, to introduce this webinar, and then I will introduce our first speaker.
Okay, thanks so much. So first of all, I would like to thank you very much, Professor Sugawara Sensei, that he spent maybe 3-4 days at the Bangladesh Congress, that he demonstrated so nice cadaver dissection. Maybe from bottom to the maybe the back, front to back. Yes, maybe. Really appreciate it. He is so recent. He is so busy because he is one of the member of the ARICLISH. So I think a regular visit to the United States, and also so many cadaver dissection which will be held in Japan. So I really appreciate your educational activity. Please continue. Thank you so much. And second speaker is the difficult name, Sharandeep Sensei. I don't see his face, but second speaker, thank you very much.
Connected. Yes, here. Yes.
ありがとうございます。すいません、どうも。はい。So I think we are very much looking for the two lectures. Shin, thank you very much for your join and demonstrate your lectures. Thank you very much. Then, Albert Sensei, please start.
Thank you, Professor Kato. So it's my pleasure to introduce the first speaker. Professor Takashi Sugawara is, first of all, a dear friend of mine. So it's a particular pleasure for me to introduce him. And he is very well known for skull-base surgery. He is currently professor at the Department of Neurosurgery at the International University of Health and Welfare Narita Hospital. And previously, he has been postdoctoral fellow at the Department of Physiology, Loma Linda University. And as Professor Kato mentioned, he has been cerebrovascular and skull-base research fellow at the Arkansas Neuroscience Institute. He is board member of many societies. It will be very long to list them all, and he got many awards and honors. He is also author of several papers about cerebrovascular and skull-base surgery. So today, Professor Takashi Sugawara will talk about surgery for lesions around the cavernous sinus, tumor, and aneurysm. So, Professor Takashi Sugawara, thank you very much for joining us, and you can start sharing your screen and your presentation.
Thank you very much. Okay. Can you see the full screen?
Yes, right? Yes, we can.
Okay. Hello, everyone. First of all, I'd like to say thank you very much for giving this opportunity to everyone who is involving this conference, and especially for the Professor Sayoko Kato. And today's my topic is about the surgery for the region around the cavernous sinus. And as Alberto told, I learned the scopes and Dr. Krish, especially for the cavernous sinus surgery, and these are my mentors. And surgery for the region around the cavernous sinus involves risk of cranial nerve injury, especially for the tumor invading cavernous sinus of 𝒕𝒓𝒐𝒏 and 𝒂𝒏𝒂𝒃 and paracrineal aneurysms. So radical resection, radical treatment of such a lesion is still challenging. So I show the surgical strategies and technique with interpreted video. And first, about the tumors. The treatment strategy for the tumors around the cavernous sinus. We have to preserve cranial nerve function and the internal cardiac artery. So resection as much as possible, followed by the ablation or radiation therapy. But this resection as much as possible depends on the surgeon's skill and the experience. So for some neurosurgeon, it means no resection. And for the other neurosurgeon, gross total resection. Here is a stereotactical radiosurgery for cavernous sinus. This is just for making tumor. The tumor control ratio is about 90% for 10 years. So this is, I think, very good result. But as for the symptom improvement, about only 30%. I think this is not good enough. So for me, the surgical resection indicated for the patient with neurological symptom or tumor rapid growth. But when the tumor is considered too stiff to remove without damaging the cranial nerve, the tumor in the cavernous sinus is left in place. When the patient has neurological symptoms such as diplopia, ptosis, and the visual field deficit, the optic canal, and even if the I gave up to the removed in the cavernous sinus, the optic canal and the 𝒂𝒏𝒂𝒃 are widely open, and the lesion in the optic canal and the 𝒂𝒏𝒂𝒃 are aggressively removed to decompress and restore its function. And here is the anatomy. I think everyone knows this anatomy. There are many triangles getting into the cavernous sinus, and also the Dolenz triangle. And this place, the Okumura cave. This terminology was written in the text written by the Dr. Roten, and there are some big cave around the Okumura now. And here is some approaches to the cavernous sinus, and extradural temporal approach, the transpetral approach, or the combined with of the 1 and 2, and recently the transnasal approach. Many people use this approach. And here's the anatomy of cadaver dissection. This picture is, I think, the most important picture. Like, you know, there are already removed the anterocranial process, and here is the optic strut. And you can see a C2, C4, 𝒂𝒏𝒂𝒃 nerve here, and coming up here in the 4th nerve, 5th nerve. And also the 6th nerve is behind the B1 and running like this way. So I think that 6th nerve is most difficult to find and preserve. So here's another cadaveric tissue. In this picture, the 6th nerve cannot see, but behind the medial to the V1, you can see a 6 nub here and coming down. Actually, the 6 nub is coming from the preponderant system and through the Dolores canal and in the into the cavernous sinus like this way. I think this is the most difficult place to find the 6 nub to remove the tumor. And I show the anatomy with the malignant tumor resection. And here is the anterior process, the fourth nub here. And SANAB is running just laterally. And this procedure is important. I think that make the anterior process as smaller as possible, and remove the anterior process, and also do the optic strut to make the space in front of the C3, and get into the dural space. And here is a optic nerve here, and here you can see the V1 branches, some fiber of V1, and then you can see the fourth nerve here, and cutting these nerves because this person is for this surgery is for the malignant, so I sacrificed all these nerves. SANAB is very big, and just beside the optic strut here. And another malignant case is open the cavernous sinus lateral, the SANAB here, fourth nerve here, V1 here, and cut the optic nerve. They also open the paramedial triangle here, and you can see the IC C4 here, and cut the V1 and flip the V1, and you can see a 6 nerve here, and also cut these nerves. SANAB is very big nerve, and you can see C3 and proximal ring and C4. Actually, proximal ring is not ring. This is carotid oculomotor membrane. And remove SANAB and fourth nerve and V1 and 6 nerve, and then move C4 backward and remove the tumor unlock. In this case is a cavernous meningioma case, and small, but she had a progressive locomotor and medicinal policy, so I decided to remove. Actually, decompress these nerves. And here's a video. And expose the lateral cavernous sinus beyond VTPC here. And in the interdural space here, I see and SANAB, I find SANAB here. And go back to the lateral cavernous sinus and open the anterolateral triangle here. This place is usually a very safe place, but sometimes the 6 nerve was pulled down like this by the tumor. So sometimes we have to take care of 6 nerve. And once I found the 6 nerve, I can remove the tumor aggressively. And here we can see the SANAB compressed medially here, and open the oculomotor, cut the tentorium, and open the oculomotor cave to decompress the SANAB. This procedure is most important for her to restore the oculomotor nerve function. Here you can see the SANAB and oculomotor cave here. And continue to decompress the sarna. And the sarna runs like this way and turn this direction. So continue to open the modal cave widely here. I took a long time to do this procedure. And I also open the optic seeds here. And to remove the tumor invade to the dura optic seeds like this one. And open the anteromedial triangle with the lens triangle here. And here is a very safe place. No critical structure here. And here is a pyramidal triangle. And open it and develop the tumor here. Synapse. The fourth synapse must be lining here. But I couldn't find the sixth synapse because the tumor covered. And continue to develop the tumors. Yeah. And open the Parkinson triangle. Actually, I couldn't find the sixth, but must run here. So cut the close place to the B1 and get into the Parkinson's triangle here and develop the tumor. And finally, I found the sixth nerve here. And once found the sixth nerve, I aggressively remove the tumor like this with observing sixth nerve. And then here is a posterior fossa through the Parkinson triangle here. And sixth nerve and Doleros canal here. And this is the final view. And of course, I couldn't remove all of them. Still left some tumor here. But this is a preoperative Simpson upward restriction and side apoptosis. And but 1 week later, this is Simpson recovered almost completely in 1 week. And another case, I show a little bit bigger tumor in cavernous sinus, like this way. And she had the severe abducens palsies and visual field deficit. So I decided to remove this tumor. In this video, also long, so I'm gonna skip some place and removing the antigen process like this is a similar making the supraorbital fissure here. And start to peel the temporally appropriate from the cavernous sinus lateral wall here. And remove the antigen process tip. And here you can see the C3 here. And cut the dura longitudinally to the cerebellum fissure and open the cerebellum fissure. Not a big opening, just open the deeper part of the cerebellum fissure and expose the IC here. And here you can, I'm now finding the sarna. Here you can see the sarna compressed medially and anteriorly. And the sarna was, the funny like this. And then here is a posterior fossa. And cutting the anterior petrocranial ligament here. And opening the paramedial triangle. I mean the posterior part, posterior place from the oculomotor nerve here. And develop the tumor here. Continue to develop here. And all the way to the end of the tumor. That means the posterior fossa here. And we can find the basilar artery. This is actually the use this place to the transcavernous approach to the basilar artery. And here is Dolenz triangle. That means anterior part with the from the third nerve. And also cut the tentorium anteropetroperoneal ligament like this way, gently and softly. And this is a third nerve, finding third nerve here. And slowly cut here. And here is a lateral triangle between V2 and V3. And as I told you, here is a very safe place. Usually the safe place to get into the cavernous sinus. And also posterior triangle. Here is a trigeminal impression here. And also the anterolateral triangle here. And checking the IC by the Doppler and the V1, V2 here. I'm going to skip a little bit here. And again, the anterolateral triangle here. And this is a optic nerve, and then you open the optic cyst here, and you can see the IC here. And decompress right optic nerve to restore the optic nerve function. Here you can see the tumor compressing the optic nerve. This decompression is also important to restore the function. And is a posterior triangle. I try to find the sixth nerve here, but as I told you, sixth nerve is very difficult to find, especially like this tumor case. So in the end of opening the Parkinson triangle wider, the fourth nerve you can see here, and continue to develop the tumor in cavernous in Parkinson's triangle. Yeah. I'm going to speak here. And here's the fourth nerve and Parkinson triangle and the parameter triangle. So I'm remove the tumor in the posterior fossa. And this is a arachnoid membrane in the posterior fossa here. Here you can see the intradural space, and here is interdural space. I mean the cavernous sinus. Cavernous sinus is actually the interdural space. I mean the extradural place. Same as the spine extradural space. Here is the intradural space, intradural space, and the dura here, and the basilar artery here. So I'm finding the sixth nerve, but the sixth nerve must be more laterally, and this is I think a good picture for understanding about this. Here is the intradural space, and here is the interdural space, actually the cavernous sinus. And the sixth nerve must run like this way. but in this time, I thought it is risky to find a 6-nab and remove the tumor around the 6-nab for this case, so I gave up here. But decompress the SARNAB like this way, and let's triangle. Here is in the camera sinus, and here is the IC system. And also we'll continue to remove the tumor in the cavernous sinus here, and 4-snap here, and 5th-snap root, like this. 5th-snap's root of 5th-snap is run here. So if I have like to find the 6th-snap, I should make the approach route from the laterally. I mean the anteropetroidal approach here. But in this case, this is the final view. SARNAB well decompressed and post-NAB and beyond BTPC. Yeah. So I gave up, remove this place because 6-NAB must be through this tumor, like this way. So the visual field deficit almost completely recover, but her abducens palsy he didn't recover. Actually, I think the abducens nerve was well decompressed, but I think her symptom was lasting a long time. So I think it is because this abducens palsy didn't recover. But I don't know why, but she didn't complain of diplopia at all. She can spend usual life. This is fortunately happened. And the next case, she has almost complete right oculomotor palsy, but she was 74 years old, and the tumor in the cavernous sinus was too stiff here, too stiff to remove. So I gave up to remove the tumor in the cavernous sinus, but I had to remove the decompressed SARNAB here. So here you can see SARNAB, fanning SARNAB, and I'm decompressing the SARNAB, cut the tentorium, anteropetrocrine ligament, and opening the oculomotor cave here, and remove the tumor behind the SARNAB like this. This is the most important procedure for her to restore the oculomotor nerve function. Here you can see the SARNAB well decompressed. And actually, I think it's a little bit difficult to see, but here you can see the SARNAB, compressed SARNAB. And after the surgery, can you see this SARNAB well decompressed and relaxed? That one. And then her symptom improved completely in 8 weeks, like this. And the next case is a PNET case, pituitary neuroendocrine tumors. She underwent the endoscopic transfemoral resection, and then gamma knife for the residual tumor, and still the recurrence still recurred like this way. So I was asked to remove via transcranially. So I did the resection here in the lateral triangle. That pitnet is usually very soft and suckable, so it is kind of easy to remove. But if after the gamma knife, I think might be difficult because the tumor turned into the stiff. But in this case, fortunately, the tumor is suckable. Tumor was here is in the intradural space, and cut this space usually it is easily removed from the transphenodal approach by endoscope. But still, we can remove tumor here by transcranially, like this way, and then cut the paramedial triangle here. And here you can see the tumor soft and suckable, and cut the tentorium here to the posteriorly along with the sternum. And of course, the decompression sternum is most important for the heart, and push the germata. And here you can see the fifth C5 here, and continue to develop. And here you see the sixth nerve here, and this is the final view. And just after the surgery, she has severe glomerular palsy like this, almost no movement without the lateral. But 3 months later, this symptom, this palsy, almost improved completely, like this way. And this is the clear cell meningioma in the microscope case, and heterosectomy here, and peel the temporal propria from the lateral. Actually, the open the microscope here, and removing the tumor here. And in this case, I sacrifice fifth nerve and V3 because this tumor is clear cell meningioma malignant cases and do very rapid growth. And here I confirm the IC here and remove the tumor in the posterior fossa. Here you can see sixth nerve here, and confirm the 7 and 8 nerve by the endoscope, and this nerves far from the tumor. And open the liver ligament here, and here you can see 6 and the med. And in this case, there is a hetero basal sinus here, or the petrosal sinus here. So I had to preserve this sinus. So I use two windows, lateral place from this sinus and then medial side of the this sinus. Here you can see the pons touched to the tumor touched the pons, and cut that and I found the medial end of the tumor here, and the cut here. And this is the final view, the pons and 6 nerve 𝒂𝒂𝒏 here. And the tumor was totally removed, and his business nerve palsy completely improved like this way. And I did about more than 23 surgery recently, but for majority of these cases are meningioma or the schwannoma cases. And the 12 cases operated to improve external ophthalmology, almost about 80% symptom recover. But some cases can accident recover that function. One case is a case of long-term persistent symptom. And this one case was a recurrent case after removal and gamma knife therapy. So the tumor was still firm to the compressed now. And as for the visual field disturbance, almost all these disturbance recover at least partially. And can I have time? Continue? Can I continue?
Yes, you can have some more minutes. Yes.
Okay. So here I'm going to talk about the aneurysm. And the endovascular coagulation is increasing very favorably even for wide neck aneurysm, but using stent. However, neck clipping is still necessary for some kind of aneurysm. So to provide clipping as a viable alternative treatment, the procedure safety and the reliability are extremely important. To accomplish safe and reliable neck clipping, achieve complete aneurysm exposure and visualize perforating arteries, promote nerves, and clip tip while clipping procedure. And to optimal surgical exposure can be achieved by the sufficient drilling the sphenoid ridge and removing the anterior process if necessary, and wide opening the silver fissure and the mobilization of temporal lobe, and removal of the anterior fold. And I'm talking about this oculomotor mobilization with temporal cut. And this oculomotor nerve mobilization is very useful because here you can see the this picture. I can't see the all the aneurysm, especially the proximal neck, but I cut the tentorium and open the oculomotor cave. This make it easy to see the aneurysm. And I'm going to skip this one. And I'm sure some cases. This is a SH case, the left ICPC ruptured aneurysm. You can see the I can't see the aneurysm at all, but cut the tentorium and you can see sarnab and the proximal neck here, but still impossible to insert, apply the clip. So continue to cut the tentorium here. And here you can see the sarnab and peel the sarnab away from the, and apply the clip here. But still the aneurysm has a blood flow, so I continue to remove, peel the sarnab away from completely, and then apply the another clip, complete clip. And she has a transient site oculomotor palsy, but complete recovery in 4 months. And also the impending rupture, she has the oculomotor palsy, and here you can see the sarnab, but couldn't see the aneurysm at all. But here is the aneurysm and the tentorium here, and try to expose the aneurysm, but here's an aneurysm neck. I can't see by using the mirror, so cut the tentorium like this. Here is a very safe place because I can see the sarnab here, and the aneurysm is another side. It's a very safe place, but still not enough space to insert the clip. So I decided to add the anterior here. Then the tentorium was relaxed, and here you can see we make the space here, and also I can cut the tentorium here safely because I can see the aneurysmal proximal neck here. But then applying, and of course have to confirm that there is no perforator. I can see the perforator here, but no perforator behind this aneurysm. Here's a posterior common artery, but still I need to confirm all the aneurysm. So cut the tentorium further, and then removing the part of the tentorium here. And here you can see the aneurysm through the sternum. And then her oculomotor palsy recovered in 3 months. And this is another case, ICPC and the basilar aneurysm. There is no space to insert the clip, so I open the tentorium here, and you can see the aneurysm here. This procedure can make it easy to observe the aneurysm, but also the mobilized oculomotor nerve. Oculomotor mobilization is very useful to go to the basilar aneurysm. Here, I push the sternum laterally here, like this. But I didn't damage the sternum permanently because the sternum was relaxed here, and she has slight transient motor palsy, but a complete recovery. And this shows the Dolenz approach with suction decompression technique. I'm going to skip here. And here the optic nerve compressed medially and open the optic sheath like this way. Same. And cut a dural ring, decidual ring, and exposing the proximal neck of the aneurysm here. But it is kind of hard to see here because the aneurysm tension and the risk of rupture aneurysm. Then I apply the temporary clip here and suction the blood and compress it aneurysm like this way. And this can make it easy to apply the penetration clip like this way. This suction decompression technique is very useful, I think. And this is the last case Dolenz approach to the qualitative aneurysm, and also opening the unloosening the and cut the peel the temporally appropriate from the Japanese sinus and all the way to the anterior process tip to safely remove the anterior process like this. And I'm going to skip here. It's a huge pneumatization of the anterior process. And then opening the optics canal, and here's the optic strut. In this case, optic strut must be removed all of the strut because I have to get in this place. I mean the anterior place of the C3, and open the dura, and observing the intradural structures like optic nerve and the C2 here, and open the optic cyst here, and here you can see the distal dural ring here, the optic ophthalmic artery here, and then cut the distal dural ring here and the C3 here, and it is I had to cut the distal dural ring all the way to the other side of the C3, because we have to mobilize the IC to insert the clip safely, and also insert the temporary clip here to the C3 safely, like this. Actually, this case is better. It was better to cut the distal dural ring 360 degree, but maybe I cut the 330 or 40 degree. Aneurysm here and the become artery here, and the medial side also. Here you can see the suprahypophyseal artery here, and the aneurysm. All aneurysm was interdural space. This case. And continue to cut the distal dural ring here. This bleeding was from the cavernous sinus. Same, the bleeding is from cavernous sinus. Okay. And then apply the penetrated clip like this, preserving the suprahypophyseal artery. Here. And this is a IC ring, shows normal blood flow and no flow in the aneurysm. This is a final view. And close the dura with fat tissue watertightly. Okay, I made the model for the anterior peritectomy or exposure of lateral cavernous sinus, and also the anterior peritectomy. I skipped this video because I think it's that my time is over. So, but I think this is very useful for training for this kind of approach. My younger colleague Wayne wrote a paper for the neurosurgery about this model. If everyone interested in this model, please read this paper. Here is a conclusion. And also, I'd like to talk about the first Congress with Neurosurgery Academy. It's gonna be held on the June 4th to 7th this year. This academy was, then Professor Armesti and Dr. Professor Christ established this academy for training the young neurosurgeon in the world. So this is a kickoff meeting in Istanbul. So everyone interested in this microsurgery, please come and join us this June. Thank you very much for your attention.
Thank you, Takashi. Thank you very much for your very nice presentation with so complex cases. I would like to open the discussion now, first by asking Professor Ashish Kumar. Ashish, do you want to give your comment on the lecture?
This is it's an honor to actually see these approaches, because cavernous sinus is one region where most surgeons now, prefer radiosurgery just because of the ocular morbidities and postoperative ophthalmoplegia. But it's very nice to see Professor Sugawara's results, because I think the recovery of all of third nerve or the sixth nerve paralysis almost was complete in most of the cases, except for 1 or 2 cases in his series. So very, very nice to see these approaches. And I think it also goes to tell the amount of cadaveric dissections which he has done, because I think for anyone who is picking up skull-based cases, I think before we start operating on these cavernous sinus lesions, it's important to know the anatomy of the cavernous sinus as explained. I just wanted to ask one question, Professor Sugawara. If you are looking at the pre-op MRI, how do you decide that this tumor is a soft one, or this tumor is a tough one or a hard one, or the consistency is firm and will cause difficulty in? Because I think that is the important criteria to select surgical approaches versus non-surgical approaches as per your recommendations. So I think the young surgeons will really appreciate if you can kind of elaborate on the MRI findings, or on the areas where you think you can predict the consistency of the tumor during the surgery, before the surgery. Thank you.
Thank you very much for your asking. I think it's very important. But actually, yeah, I cannot predict the stiffness of the tumor before surgery. Actually, we can guess, but actually we don't know the guess is correct or not. But as I told, my surgical indication is to restore the cranial nerve function, right? So if the tumor is too stiff to remove in the cavernous sinus, I give up to remove the tumor in the cavernous sinus, but I never give up to remove the tumor in the oculomotor cave, because I have to decompress the oculomotor cave. And in my experience, that in the tumor in the cavernous oculomotor cave is usually soft, actually, sometimes not so, but for me, it's not too firm, not too stiff to remove. So, but sometimes, in my impression, if the symptom has lasting for a long time, like onset was more than 3 or 4 months before, I think it is very difficult to decompress the third nerve. So that was the case. I couldn't restore the function. So I mean, it is difficult to predict hardness. Of course, I can guess, but it's not easy.
Yes, I think on MRIs, especially if there is more on T2 weighted images, you can always just predict. You may not be correct, but if it is more hyper intense on T2 weighted images, that means it has more water content. You can probably try to predict, but as you said, like, you can only guess. You'll only see during the surgery. So it's good to know that you can change the plan during the surgery if you feel that the tumor is firm, rather than trying to manipulate the nerve structures there. I mean, apart from this, like in cases of tumors where you find that there is not significant planes between the nerves, because I think all the videos had very good dissection from the third nerve and the sixth nerve. in the cavernous sinus. Do you change your strategy? For example, if there is no clear plane between the nerves and the tumor, or the tumor has kind of infiltrated the perineurium or something like that?
Sorry, I can understand.
If suppose your nerves, the plane between the tumor and the nerve is not very good, do you leave a little bit of a tumor on the nerve, or your
of course, yeah. I think it is very difficult to decide to risky or not risky, but yeah, that is the most difficult how to say strategy. But if I think it's risky to big risk, I give up to remove the tumor and leave the tumor on the nerve. But actually, I try to decompress the nerve, just decompress. That means
先生、この神経と腫瘍との間にこうダイセクティングプレインみたいなのはっきりわかるんですかっていうような質問なんですけど、だからそのダイセクションする面がちゃんと分かれてるのかどうかってことを多分聞いてるんだと思うんですけど。
Yes, actually, it's the same thing. If I cannot find the dissection plane, I mean on the surface of the nerve, I just do the decompress, debulk the tumor.
Okay.
Thank you. And you never, in some cases when the tumor is larger, or we are going for, and you expect that this is a vascular lesion, do you sometimes try to embolize them preoperatively, or this is too risky in your opinion?
It depends on the endovascular surgeon's skill, I think. But yeah, I have experienced one. The tumor was very high vascularized case, and bleeding a lot from the tumor. In that case, I gave up to remove the tumor, but also just try to decompress the cranial nerves. So I have never embolization before surgery.
Normally, we don't also try to embolize in this area because there are a lot of natural connections between the external carotid artery and the internal carotid artery branches, especially the ILT and the meningohypophyseal trunk. So in case of embolization, there is a high risk of throwing something in the IC circulation. And you will not actually see on the angiograms unless you are pushing against resistance, and then these connections open up. So it's not a very likely, there's not high chances of embolizing or having a great success, because I think surgically you can kind of try to take the vascularity directly rather than embolization route. Thank you so much.
I agree with you, and I have experienced coagulate the meningohypophyseal trunk directly in the tumor.
Yes, much safer. Thank you so much. Excellent presentation.
Thank you, Ashish, for your comments. I see we have some questions from the floor. Dr. Hui?
Just I have two questions. The first is there any role of intraoperative monitoring for the surgery of the cavernous sinus, especially for the oculomotor nerve that you use in the institution?
Yes, I usually use NIM monitoring, but that is not stable. So, and just use for just finding the nerve, but actually sometimes it doesn't work. So
Yeah.
I have to, I think I should improve the monitoring.
Yeah. And in my hospital, there are several patients who come to us after the failure of gamma knife. And do you have any special consideration for those cases when they come to you regarding the indication for surgery and the experience during surgery for those cases?
Sorry, again?
Yeah. Several patients that come to neurosurgeon after gamma knife. They have gamma knife first, and you have experience regarding the indication for surgery for those patients. You are more conservative with those patients, or you still the same? And also the experience for the intraoperative findings for those cases.
Actually, I showed not case. I told in the presentation, I have one experience who underwent the surgery and recover, and she had a gamma knife, and then still regrowth that was, and then I operated on her, but I couldn't decompress the sun because the tumor was too stiff. So actually, I couldn't decompress, and her symptom lasting.
先生、ガンマナイフの後、なんか違った感じがありましたかみたいなことはどうでしょうか？
Yeah, yes, so I mean the gamma knife, after gamma knife, the tumor become stiff, hard, and I couldn't decompress the third.
So that means fibrosis? After
Fibrosis,
radiosurgery?
I'm not sure about the fibrosis or like
Granulosis.
Granules, yes.
I see. Wait, you
Yeah,
understood?
thank you. Thank you for those sharing.
So I recommended the surgery before gamma knife if the patient has some symptom.
Yes, thank you.
Thank you. Ishu?
Yeah, thank you. Thank you so much for the wonderful talk, Professor Sugawara. I have one question. Like in recurrent cases in which you have operated first and they are recurring again. So I think the adhesions, they are more with the tumor. So do you have any experience of recurrent cavernous sinus tumors like meningioma, and how was your experience in recurrent cases?
So if recurrent cases, in my case, I think, the first surgery, I tried to remove as much as possible. And then the tumor recovered. That means I couldn't remove all of the tumor, right?
Yes.
So in that case, if the tumor, recovered to the toward the sarnab, and I thought I think I can remove the tumor. I mean, the decompress the nerve. I try to remove again, but usually I think it is impossible. So in that case, I do the gamma knife for meningioma case. But like chondrosarcoma or pituitary adenoma, either this kind of tumor recur, I think I can remove, the decompress. So I have the experience to second surgery in such chondrosarcoma or pituitary adenoma cases, but not for the meningioma.
Okay, then I continue. The chondrosarcoma, it's a quite rare tumor. They're so how was your experience for the chondrosarcoma? Because they are radio resistant and other possible treatment, they are not applicable to them. So,
But actually, the chondrosarcoma case, proton beam is now we can use a proton beam, or sometimes gamma knife is effective for the chondrosarcoma cases. But chondrosarcoma is usually a soft tumor.
yeah, soft circuit. I have one experience with chondrosarcoma.
Yeah.
That's why that triggered.
Yeah, so it depends on the age of the patient, but usually I try to remove again. And then the radio surgery.
Yes, surgery is best. Professor, you had made very nice videos and the presentation are awesome. Like the videos, they were very illustrative. I like that very much. So thank you so much.
Yeah, thank you.
Yes, actually, I agree. The videos were very instructive because we could see the anatomy and the anatomical relationships between nerves and vessels and the tumor, and how the tumor can alter this anatomy. So thank you very much, Takashi, for this wonderful lecture, and also for the very nice discussion. I think young neurosurgeons got a lot of benefit from this presentation and from this talk. Thank you very much.
Thank you very much.
I think, Ishu, we can move on with the next speaker. So you can introduce him. Thank you.
Thank you, Alberto. So I would like to invite our next speaker, Dr. Charandeep Singh. He is my junior from J.B. Pant Hospital, from where I did my neurosurgery. And currently he's working as assistant professor at AIIMS, Raipur. And he is a neurosurgeon, and he has published many papers, and a member of NSI and NSSI. Today he will be talking on subarachnoid hemorrhage guidelines 2023. What's new? So you can continue. Yeah, we can see your slide. Yeah, Charan, it's visible.
Yeah. Thank you, Prof. Ishu, for the kind words and for the wonderful introduction. Thank you, Prof. Yoko Kato, for this opportunity. My previous speaker, Prof. Has made a very interesting presentation. I am going to speak on aneurysmal SAH 2023 guidelines. What's new? So these guidelines came out in 2023, which are endorsed by the following societies: the American Association of Neurological Surgeons, the Congress of Neurological Surgeons, the American Academy of Neurology, the Neurocritical Care Society, the Society of Neurointerventional Surgery, and the Society of Vascular and Interventional Neurology. So all these societies have endorsed these 2023 guidelines for management of patients with aneurysmal subarachnoid hemorrhage. So before I begin, this slide will form the gist of my talk. So I want you to just brush up the class of recommendation and the level of evidence. So if it is a class 1 recommendation, the suggested phrases for writing recommendations will be: it is recommended, or it is indicated, should be performed or administered. Or comparative effectiveness phrases will be: treatment strategy A is recommended in preference to treatment B, or treatment A should be chosen over treatment B. So the strength of recommendation in class 1 is strong, and in my further slides, it is represented with the color green. Class 2A, it means that suggested phrases are: it is reasonable, can be useful. Comparative effectiveness phrases will be: strategy A or treatment A is probably recommended to treatment B, or it is reasonable to choose A over B. The strength of recommendation is moderate, and the color coding is yellow. Class 2B, the strength of recommendation is weak. It might be reasonable, might be considered, Usefulness, effectiveness is unknown, uncertain, or not well established. So the strength of recommendation is weak, and it is represented by the color dark yellow. Class 3, no benefit. Suggested phrases for writing recommendation is not recommended, it is not indicated, or should not be performed or administered. And color coding is orange. And class 3, harm, that is color coding is red. That means potentially harmful, causes harm. If this procedure is done, it will be associated with excess morbidity and mortality. So this procedure should not be performed. And the level of evidence is level A, which is high quality evidence from more than one randomized control trials. Level B, randomized moderate quality evidence. Level B, non-randomized moderate quality evidence from one or more non-randomized studies. Level C means limited data, and level CEO means expert opinion. So what is significance of aneurysmal SAH? Usually it afflicts individuals in their working years. 26% of patients will die before arriving to the hospital, and 13% of patients will die during hospitalization. Major risk factors: family history, 12% prevalence of harboring a cerebral aneurysm in individuals with 2 or more first-degree relatives with known cerebral aneurysm. Hypertension is a major risk factor, so is smoking tobacco. Radiological screening, cost effective when performed every 5 years for individual 20 to 80 years old with family history of 2 or more first degree relatives with known cerebral aneurysms. So what are the recommendations of these guidelines? They say that utilizing clinical scales, example Hunt and Hus grade, WFNS grade, is recommended to determine initial clinical severity and predict outcome. Class 1 evidence. In high-risk aneurysmal SAH, aneurysm treatment is reasonable, but after careful discussion of likely prognosis with family members. Same goes true with aneurysmal SAH and advanced age. Aneurysm treatment is reasonable after careful dissection of prognosis with family members to improve survival and outcome. And in patients with aneurysmal SAH who do not improve after correction of modifiable conditions or are deemed unsalvageable, treatment of aneurysm is not beneficial. Class 3, no benefit. So the initial assessment checklist will be headache, which is like the worst headache. Everyone knows worst headache of your life. Sudden onset, sentinel bleeds can be there. Presence of new neurological deficits. And there is a Ottawa SAH rule, which is a class 2B. That means strength of recommendation is weak. But this Ottawa SAH rule states that for alert patients more than 15 years of age with new severe non-traumatic headache reaching maximum intensity within 1 hour, you have to go ahead and do additional imaging for SAH if they meet any of the following criteria: age more than 40, neck pain or stiffness, witness loss of consciousness, onset during exertion, thunderclap headache, or there is limited neck flexion on examination. So the patient presenting to you with acute onset of severe headache, either less than 6 hours or more than 6 hours. And if he's presenting with severe headache, more than 6 hours, new neurological deficit, you will go ahead and do a non-contrast CT. And if there is aneurysmal SAH in that, you will go ahead and do a CT angio or a digital subtraction angiography. And if their non-contrast CT is not conclusive, you can go ahead and do with a lumbar puncture, which is a class 1 recommendation. Hospital characteristics and system of care. Timely transfer from hospitals with low volume case volume to high volume centers with multidisciplinary neurointensive care services, comprehensive stroke center capabilities, and experienced doctors is recommended to improve outcomes. Class 1 recommendation. So large volume centers, they have defined as centers which are doing cases of aneurysmal SAH more than 35 cases in a year. And small volume centers are which are doing less than 10 cases in a year. For patients with aneurysmal SAH, care should be provided in a dedicated neurocritical care unit by a multidisciplinary team. Class 1 recommendation. Now, this is what has come up in these new guidelines. So blood pressure control with unsecured aneurysm. So in the management of patients with aneurysmal SAH, they are not giving any cutoffs. They only say avoid hypertension, avoid hypotension, and you minimize BP variability. So you target BP is individualized according to the BP at presentation, brain edema, hydrocephalus, or history of hypertension or renal impairment in that patient. But what you need to do is minimize BP variability, avoid hypertension or hypotension. BP should be controlled with frequent monitoring and short-acting medications. If the patient is taking anticoagulation, then it's a class 1 recommendation to reverse it with appropriate reversal agents should be performed. And class 3 recommendation, which is there is no benefit of using antifibrinolytic drugs like tranexamic acid. It is not useful to improve functional outcome, so should not be used. Treatment of ruptured cerebral aneurysms. Class 1 recommendation is that all cerebral aneurysms should be treated within 24 hours from onset of aneurysmal SAH. That is preferable. Treatment goals obviously is complete obliteration, and it is reasonable to retreat partially obliterated aneurysms. General principles that you need to evaluate it by specialists, either dual trained neurosurgeons or endovascular and neurosurgical colleagues should come together and decide what is the best treatment for this aneurysm. And patients who are deemed salvageable and who have depressed level of consciousness due to a large intraparenchymal hemorrhage, they should undergo emergent clot evacuation to reduce mortality, and in the same setting, the aneurysm can also be clipped. So type of aneurysm, anterior circulation, posterior circulation. So this has come up in 2023. Anterior circulation, yes, it's an anterior circulation aneurysm. If it is there, then coiling is preferred to clipping to improve 1-year functional outcome, and it is a class 1 recommendation. In anterior circulation, coiling is equivalent to clipping in long-term outcome. That is a class 2A. That is strength of recommendation is moderate. In posterior circulation, again a class 1 recommendation, coiling preferred to clipping. Wide neck aneurysms, fusiform aneurysms, blister aneurysms, flow diverters can decrease mortality and rebleed, class 2A recommendation. That is strength of recommendation moderate. And saccular aneurysms, which are amenable to primary coiling or clipping, we should not go ahead and put flow diverters in these cases. It is actually can cause more complications, so it can harm the patients. Straightforward aneurysms, saccular aneurysms, which are amenable to primary coiling and clipping, should be either primarily coiled or clipped. Location of aneurysm, anterior, coiling preferred to clipping for 1-year functional outcome, and even it is equal to clipping in long term. Same is true for posterior circulation. For age more than 70 years, they are saying that unclear on best treatment, whether coiling or clipping. And age less than 40 years, they are saying clipping is preferred to improve durability of the treatment and outcome. So younger the patient, clipping is more preferred. Type of aneurysm, wide neck aneurysm, stent-assisted coiling of flow diverter, fusiform blister aneurysms, flow diverters are preferred. Management of medical complications associated with aneurysmal SAH. So acute respiratory distress syndrome can develop in 3.6% of patients with aneurysmal SAH. So what we can do in these patients, you have to, recommendations are, the tidal volume should be low, moderate PEEP, systematic approach to extubation, early enteral nutrition, and standard antibiotics if the patient develops hospital-acquired pneumonia. For severe acute respiratory distress syndrome, prone positioning and alveolar recruitment maneuvers can be used. Management of medical complications. So first we used to say about triple H therapy and everything, but now they are saying euvolemia. They are saying no hypovolemia, no hypervolemia. You should try to attain euvolemia. And for monitoring euvolemia, we should not use CVP, that is central venous pressure. We should use cardiac output. We should use the stroke volume variability or preload. If the patient develops hyponatremia or natriuresis, mineralocorticoids like fludrocortisone can be used. And in patients with aneurysmal SAH whose ruptured aneurysms are secured, pharmacologic or mechanical venous thromboembolism prophylaxis is recommended, class 1 recommendation. Nursing interventions are very important. Frequent neurological assessment using a neurological assessment tool, frequent vital sign and neurological monitoring. Nurses should validate whether the patient is not developing neurogenic dysphagia, which is common in 65% of stroke patients. So screening protocol prior to initiation of oral intake is a must to reduce the incidence of aspiration pneumonitis, class 1 recommendation. And early evidence-based mobility algorithm, once the aneurysm is secured, class 2A recommendation. 30% of aneurysmal patients will develop delayed cerebral ischemia, and most delayed cerebral ischemia cases develop post-bleed days 4 to 14. So for vasospasm detection, class 2A, that is strength of recommendation is moderate. They are saying you can monitor vasospasm with a transcranial Doppler, with a CT angiography or CT perfusion study. And the strength of recommendation is weak for invasive monitoring like brain tissue, oxygen monitoring, or cerebral microdialysis. So patient with aneurysmal SAH, they are saying in spite of the literature regarding IV use of nimodipine is less. So they are saying oral nimodipine 60 mg 4 hourly is a class 1 recommendation and has benefited all patients with aneurysmal SAH to delay vasospasm. So regular neurological examination should be done. You can do transcranial Doppler monitoring, consider invasive multimodality neuromonitoring if required. What is important is avoid prophylactic hemodynamic augmentation or hypervolemia. If the patient is neurologically worsening, address the confounding agents like elevated BP, ensure that there is euvolemia. If still the patient is worsening, you can proceed ahead to what is called as endovascular rescue therapy with intra-arterial nimodipine plus minus balloon angioplasty. How to manage hydrocephalus, which is associated with aneurysmal SAH? So acute hydrocephalus occurs in 15 to 87% of patients with aneurysmal SAH. And an urgent CSF diversion with EVD or lumbar drain is a class 1 recommendation. So some neurosurgeons are a bit afraid to putting in an EVD because they say that the aneurysm might rupture. But urgent CSF diversion with the EVD or lumbar drain is a class 1 recommendation. And if there is persistent or chronic hydrocephalus, permanent CSF diversion is a class 1 recommendation. With a ventriculoperitoneal shunt, it is a class 1 recommendation. And routine fenestration of the lamina terminalis is not indicated for reducing the rate of shunt dependency. This procedure, which is often combined with clipping of aneurysm, they say it has no benefit. Class 3, no benefit with this. Management of seizures. So we finished hydrocephalus. Now how to manage seizures which are associated with aneurysmal SAH? They have classified seizures into 3 types. One is onset seizures, one is early seizures, and one is late seizures. So onset seizures is at the onset of aneurysmal SAH, if the patient develops seizure, that is the onset seizure. So first, if the patient presents with no seizures, so no onset seizures, then whether anti-epileptic drugs are indicated or not. So in patients with fluctuating neurological examination and high-risk seizure features like ruptured MC aneurysm, high-grade SAH, intracranial hematoma, if there is hydrocephalus or if there is cortical infarction, then they say that it may be reasonable to consider prophylactic anti-seizure medications in patients with high-risk seizure features. Even in these patients, phenytoin is associated with excess morbidity and mortality and should not be used. They say phenytoin will cause harm to your patients. And continuous EEG monitoring can be done, and prophylactic anti-seizure medications is not beneficial in patients without high-risk features and who do not present with onset seizures. If a patient presents with onset seizures, then treat with anti-seizure medications for 7 days. That's it. Onset seizures with aneurysmal SAH, your patient has presented with a seizure, treat with anti-seizure medications for 7 days. Treatment with anti-seizure medications beyond 7 days is not effective for primary or secondary prevention of seizures. It is not effective for reducing future SAH-associated seizure risk. There is no benefit. And what is the management of seizures which are associated early seizures and late seizures? So within 7 days and after 7 days. So these are distinct from onset seizures, as they are not the immediate result of the initial hemorrhage and potentially are related to the treatment modality or post-hemorrhage infarct. And these early seizures and late seizures, they warrant long-term anti-seizure medication. Acute recovery, so use of validated grading scores prior to hospital discharge is recommended to screen for physical, cognitive, behavioral, and quality of life deficits. So in patients with aneurysmal SAH, do not forget depression, do not forget anxiety. So these psychotherapy, pharmacotherapy to treat depression are recommended to reduce the symptoms of depression, and it is a class 1 recommendation. Use of neurostimulants like amantadine may be reasonable to promote consciousness recovery, class 2B recommendation. Without depression, use of antidepressants is of no use if the patient does not have depression. Long-term recovery. So to improve your long-term outcome in aneurysmal SAH patients, screen all your patients for depression, class 1 recommendation, for anxiety, class 1 recommendation, for sexual dysfunction, class 1 recommendation. To identify cognitive impairment, it is reasonable to choose the Montreal Cognitive Assessment Scale over the mini mental status examination. And to identify long-term needs, it can be beneficial to counsel patients and caregivers regarding the long-term risk of cognitive dysfunction, class 2B recommendation. And this is my last slide. Risk factors, prevention, and subsequent monitoring for recurrent aneurysmal SAH. So after you have clipped or coiled the aneurysm, class 1 recommendation is there that you do a perioperative cerebrovascular imaging before the patient gets discharged. You do a CT angiography or a DSA to identify residual aneurysm or recurrent aneurysm. And 6 monthly or yearly long-term follow-up of cerebrovascular imaging is a must for recurrence or regrowth of the treated aneurysm, for changes in another known aneurysms, or development of de novo aneurysms. Thank you.
Thank you. Thank you, dear Charan, for the wonderful talk. So now the house is open for the discussion. So I would like to invite Dr. Ashish for his expert comments.
Thank you so much, Dr. Sharandeep, for reviewing the 2023 guidelines. I was finding it very, we have seen through it, but it's very difficult to imagine that there is no class level 1. There's no level 1 evidence for clipping in anti-circulation aneurysms. Right? If I'm not wrong, that is what, what
when
it shows.
When it came, even it was shocking. Even when I read it, it was very shocking for me too, that there is no level 1. They say that functional outcome is better with coiling than clipping, even for anterior circulation aneurysms. So more and more we are moving towards endovascular and than clipping. But still, like in young patients, they are saying that clipping is better because coiling can leave a bit of residual aneurysm, which can regrow. So in young patients, they are saying that clipping is better than coiling.
And any particular indications for or guidelines for MCA aneurysms, because that is still one scenario with an ICH where there is. I read an article where somebody said that results of coiling and then taking the patient to the OR for evacuation of the clot is same as clipping and evacuation of the clot at the same time. Any recommendations on MCA, because that is the conundrum which we face?
Yeah, so I have also gone through a few articles where people have evacuated the clot and they have not clipped the aneurysm and it's gone for coiling. So the recommendations say that in anti-ACE circulation, there is a class 1 evidence now that coiling is better. But yes, at the same time, they are saying in this guidelines that if you are taking a patient for hematoma evacuation, then might as well clip the aneurysm in the same setting. So they have said that, but yes, I have also read a few papers in which people are only evacuating hematomas and then the aneurysm is going for coiling.
Just to say that because there is, there are guidelines and there are people who don't follow the guidelines. But if for example tomorrow I do this, where I take the patient for coiling and then evacuate the clot, the problem is because there's a big hematoma, and I've seen with certain cases, not mine, but I've seen it like if there's a clot in the brain and you're coiling it. The coiling procedure itself involves giving heparin. So the clot evacuation, if you leave it alone, after 6 hours, that clot becomes double the size because the heparin causes liquefaction of the clot. So like even if it's moderate initially, looking moderate, but you are we can coil this aneurysm. After 6 hours, that clot which was small because of your heparin will actually increase in size, and then you will end up doing the surgery, as a salvage procedure after some time. So this happens most of the time, and that's why in our hospital, and it's not just us, but we have an unwritten code. If somebody does a coiling and of MCA and evacuation of the clot afterwards, like there'll be questions asked next day in the rounds, and it's not considered good. Now the level of evidence may say something else, but they say like. If that happens, that probably you don't know, or you have forgotten your open vascular skills. So this is like an indirect code where if suppose there is a neurologist on call, if there's a radiologist on call, and a patient with ICH comes along with an MCA, or for example, PCOM aneurysms, right? This also applies to PCOM aneurysms with a big temporal clot. So what do you do at that point of time? But if there is a significant clot volume, then the patient should undergo clipping rather than coiling, even if it is a simple, straightforward coiling cases. Because if you do try to coil them and not evacuate the clot, then there are chances of neurological deterioration the next few hours. And that happens because you had given heparin during the procedure. Interesting. There's just no rule of law here. That's why I think everyone follows their own practices. Well, thank you so much for your quick review of the guidelines.
Thank you. Thank you.
Yes, Alberto, please.
Yes, I also want to congratulate Professor Charandip for summarizing these guidelines. And I also was quite shocked when I first read them last year, a few months ago. Actually, I agree with you, Ashish, talking about patients with a ruptured aneurysm and hematoma, intraparenchymal hematoma. I think that the evacuation of intraparenchymal hematoma should be considered at an early stage. So I think open surgery in that case is still a very valid option. But actually, we have to face these new guidelines, and at least until new ones will come out saying something different. So I am wondering whether these guidelines are, another step into the heart of clipping. It looks like clipping is fading away very rapidly. So if we follow these guidelines, probably we have to clip only ruptured aneurysms with hematoma.
Hematoma, yeah.
Then of course, there are some cases of anterior circulation aneurysms, which actually guidelines tells us should be coiled, but that should be very well analyzed. I want to give you an example. just a provocative example. So if you have a ACOM aneurysm with just one very evident A1, and the other A1 is very, very, very thin, okay? So what about such case? If everything goes well with coiling, okay, the patient will probably do well. But sometimes I have memories of cases when the coils can reduce the flow on the only one A1. So there is no compensation from the opposite side. So I wonder whether I didn't go into in details these guidelines, but I wonder whether these guidelines took into consideration also some specific cases, because I can agree that, of course, I have to agree that there are guidelines which are very clear with very high level of evidence, but I'm wondering whether specific cases of anterior circulation aneurysms should be considered for clipping because of a very specific anatomy of the circulation. So this is my consideration and maybe a hint for discussion among you guys. Thank you.
Yeah. Nobody was commenting. Professor Yuko, like, do you want to?
No, Dr. Afzal,
yes. I was asking about the.
Just I want to maybe some short comment, because sometimes now is the endovascular era, I think, and also very good, the less invasive for the patient, both sides, the doctor and the patient. And the clipping is good for the very small, tiny aneurysm. It is difficult for treat by endovascular, and very broad neck. And that is a good indication. And also even the anterior circulation, I think Albert mentioned about the, you said, I hope, but now is no more, sometimes no more coiling, just put the stent, a flow diverter, I mean. Or sometimes the MC aneurysm will be treated by wave. It's a much shorter time and much faster. And also, even the MC aneurysm with clot, big clot. So of course we can place coil or some endovascular treatment, then followed by the evacuated clot by endoscope. That is very, very faster, and also the good, less invasive for the patient, I think. That is the current. Maybe I think it's very ideal. Then much shorter, and also less invasive for the patient and also the doctor, I think. And also, you mentioned about Fasudil, Chandip.
Yes, ma'am.
Yeah, you mentioned about the Fasudil for treatment of the vasospasm.
For treatment of vasospasm?
Drug.
Nimodipine.
Yes, ma'am. Yes, ma'am. Intraarterial nimodipine. Yes, ma'am.
No, not only nimodipine, Fasudil. I don't know. 菅原先生、ファスジルって日本だけでしたっけ
Yes, the Fasudil is only can used in Japan. Actually, no evidence.
Okay, no. Thank you. In Japan, again, another good drug. Maybe we can use in Japan and also Korea. Maybe sooner or later. Yeah?
Yes, ma'am.
No, Fasudil.
Oh. Yes, ma'am.
Maybe I ask it's written in your text, I think. So
ROCK kinase inhibitor.
Yes.
Inhibitor of ROCK kinase.
Okay.
RH kinase inhibitor.
Okay, thanks. That's my short comment. Thanks so much. Okay, please go ahead, Afzal. Unmute, please.
Unmute yourself. Afzal, unmute.
Thank you very much, Professor Chandeep, for this review. My question was also on vasospasm, if there was a new drug and Kato-sensei already mentioned it, because in Germany also we use nimodipine all the time. And then I came here and I wrote a paper on SAH patients in Fujita, and I found out that the vasospasm incidence is alarmingly low compared to where I work. And it is the same where I am doing my fellowship now in Saitama. So vasospasm is very low. So I was wondering why the reason is. I think this drug could be one reason. And I was also wondering if like the operatively treated SH, the surgeons tend to put a basal drain in it. And I don't know if this drain clears the SAH better compared to an EVD. So it would be nice if the experts can comment on it. I mean, this reducing the blood volume and prevalence of vasospasm. Can you please unmute?
Lumbar drain and EVD, comparison of lumbar drain.
No, basal drain. So when you go into clip, so into the basal cisterns, so I don't know, I wonder if this can clear out more blood from the subarachnoid space, leading to lesser vasospasms compared to when you put an EVD. So actually a lumbar drain should in principle have the same effect as a basal drain, because it's the outer space, CSF space.
So you mean it's extraventricular drainage? Both are extraventricular drainage.
Basal drain.
Yeah.
But I think Afzal, maybe I think you'd better to open the subventricular floor at least when you reach the basal cistern. Either you can put or without put the catheter, I think.
Okay.
At least open, then you can make a circulation of the CSF. It's very fundamental things.
Yeah, thank you.
Thank you.
There is one paper about injection of nimodipine into the ventricles through the EVD or through Omair reservoir. Like it's a single paper published by AIMS Delhi, and they report better vasospasm control. But like now that there are class 1 evidence or class 2 evidence, so it's a just single paper. So I don't know if any one of you have any experience with such kind of Omair reservoir used for nimodipine injection. Anyone? No, I
never heard.
Yeah.
Omair or
reservoir.
SH, yeah.
Yes.
Very unique idea. Sugawara Sensei, how do you think?
I've never experienced, and I don't think it's effective. I know the magnesium or something like that is maybe effective. There are some paper showing the evidence of the magnesium injection. Well, and also I know the nicotine pellet. Put on directly on the vessels, arteries. Nimodipine pellet. カセヤ先生がやってるやつありますね。Dr. Kaseya made. That may effect.
I say more effective through venous transfusion, I think.
Yeah.
Not on my ear.
Yeah.
Intra.
Yeah. Dr. Hari?
Hello. Thank you, Professor Charandeep Singh, for the very nice presentation. I noticed two things during the presentation. One is giving a tranexamic acid. As I understood from the presentation, there is no much great benefit of giving, but still at our center, we continue to use, maybe because of our satisfaction. At the initial first or second days, we do give tranexamic acid for all SH patients. And the second thing is regarding anti-epileptics. It is very difficult to control not to give anti-epileptics to our SH patients. even though they don't get any seizures, we still give. So I just wanted to ask, at your center, how many days do you give anti-epileptics?
So after these 2023 guidelines came out, now we are using anti-epileptics and we are following the guidelines. So if there are onset seizures, we are giving it for 7 days. And if the patient develops seizures because of high risk factors, or because of cortical infarct, or because there is a huge hematoma, hydrocephalus, or there are early seizures or late onset seizures, then we are giving it for quite some time. So the basic in this guidelines is that for onset seizures, that was because of the SH, because of blood in the system. So once the blood clears out, there is no need of anti-epileptic. So onset seizures, you have to give anti-epileptics only for 7 days. But if there is early seizure after aneurysmal SH, there is delayed cerebral ischemia, there is vasospasm, now there are infarcts in the brain, then and the patient throws seizure, early seizure, late seizure, then you have to give anti-epileptics for a long period of time.
Yeah, thank you then. But most of the times we do see that the blood doesn't go away in 7 days. It takes some time, mostly around 2 weeks, 2 weeks to maybe some 3 weeks. So do we continue to give anti-epileptics till we see some blood in CT scan, or do you have any like?
Yeah. So we are following the guidelines at present, giving it for 7 days. There were no breakthrough seizures or anything of that sort. But I think that's valid for our mental peace and everything. We can continue giving it for maybe 2 weeks till the blood is cleared from the ventricular or the subarachnoid system.
Yeah. Thank you.
Thank you.
Actually, I'll just like to add in here, for tumors or for SAH patients, it was our in the genes to start, genetic. It will come and the first order will be either giving anticonvulsants. Here, at our setup, we don't even give it for tumors. We don't give it for SAH patients unless somebody presents with a delayed onset seizure. So even in trauma, there's no role of prophylactic anticonvulsants. And I've seen in my eyes, and now I believe in it. Earlier, it's more like if you start to do something else or start to change the practice at your own level, your other colleagues will actually say that, okay, this is not needed, and they will actually force you to start something. But if you follow the guidelines, as Dr. Charandeep was saying, as a group, I think you will see that you can avoid it in most of the patients.
Yeah, absolutely.
Yes, I think Dr. Opara.
Yeah.
Okay, thank you. Thank you so much, Professor Charandeep, for the presentation. I have 2 questions. One is about when to intervene for patients that come in more than 24 hours after the bleed. So in where I practice, most of the time our patients will come 3 days, 4 days after the bleed. When do you intervene in those kind of patients? Because I've seen some publications that say you should wait until the time of vasospasm is over before you do something, while you just give your regular medical management till then. While some people would say, oh, go in as soon as possible. So I just want to know what your take on that is. And then the other question is, what do you do when you have a patient that comes in like 3-4 days after the bleed, and you do a CT angiogram and you can't find an aneurysm? What do you do? I've had a patient who came in on the first day of the bleed, decided to sign against medical advice, and returned 4 days later with a massive MCA infarct. And when we did the CT angiogram, we couldn't find the aneurysm. So what do you do in that situation? Thank you.
Yeah. So for your first question, at our center, it depends on the GCS of the patient, first of all. If the patient is of good GCS, M5, M6. So next available OT slot, the patient goes in the OR. So because we don't want to lose the patient. So if he rebleeds, then so M5, M6 patient, next available slot, maybe if it comes on a Sunday and the next available slot is Monday, so maybe after 24 hours, the patient will be taken in the OR. The question arises for poor grade aneurysmal SAH patients. So in that case, if a patient is like M2, M3 status, and then we sit with the relatives, we counsel them what we are going to get and everything. And if the patients want treatment, want to secure the aneurysm, we tell them everything, what the outcomes will be and everything. And if they are ready for the surgery, we take them also for either coiling or clipping. So for M5, M6 patients who with a good GCS, good Hunter's grade, WFNS grades, directly go for either coiling or clipping. The poor grade ones depends. We sit with the family relatives. What exactly we are going to, because we are in a developing country in India. So I mean, what we are going to achieve by clipping a M2 patient who is M2 or M3, and what added burden that patient will have on the family who is already poor. So we need to sit with the family, discuss with the family, and then if the family is acceptable that yes, you go ahead and treat it, then we go ahead and either coil or clip that aneurysm. And regarding the second question, I think probably with a massive MCA infarct, already severe vasospasm has set in. So the best thing will be to go ahead and do a DSA, which is a gold standard, I think. If a CT angio is not picking aneurysm and you are highly, you can go ahead and do a digital subtraction angiography. And if the DSA comes positive, then treat it. If it comes negative, then we wait for 3 to 4 weeks for a repeat DSA after 4 weeks.
Okay. Thank you.
Thank you.
Dr. Harshila, you can ask. Unmute yourself.
Thank you very much for the opportunity. My name is Toivo. I'm one of the fellows at Fujita Health University, Banteino Hospital, under the mentorship of Professor Yoko Kato at the moment. Thank you very much, Dr. Charanti, Professor Charanti, for a wonderful detailed presentation. I just want to ask two small questions. The first question is, I came across an article recently that was published last year, where they found evidence of favorable outcome at 6 months compared in patients that received a prophylactic lumbar drain, in aneurysmal subarachnoid hemorrhage patients that received the prophylactic lumbar drain. Was this considered in the current recommendations that came out? Is there preference in terms of external ventricular drainage versus lumbar drainage based on this? Because it was a randomized clinical trial that was carried out in 19 centers in Germany, Canada, and Switzerland.
I didn't get your question. So your question is whether EVD is better or a lumbar drain is better, or,
yes.
or what?
Yes. Is there any recommendation of one over the other, based for example, from this recent clinical trial? It's called the early drain trial.
No, as far as I recollect from the current recommendations which have come in, they have just said that either a bundled EVD protocol has to be followed, or you go ahead with a lumbar drain, depending on the pattern of hemorrhage and everything. So they have not said that one is better than the other
Okay.
in
Okay.
these guidelines.
Okay, thank you. And then secondly, more of a just an additional comment than a question. I see in the discussion we were moving towards a conclusion that we in the endovascular era, it looks like the only aneurysms that may end up requiring clipping is ruptured aneurysms. Maybe just a small comment, because in my reading, I came across the fact that M1 segment aneurysms, especially located on the superior wall, tend to have perforators originating from the dome of the aneurysm, and they may not be amenable to endovascular treatment. So this is probably one of the categories that may still require coiling using multiple well-designed clips, well-placed clips to avoid including these perforators. Thank you.
Thank you. Thank you.
Okay, thank you for your comments. I see Ashish also raised.
Professor Sugawara can go first. I just have a comment.
Actually, I'd like to mention about the prevention of the vasospasm in Japanese situation. Nowadays, recently we can use 𝒂𝒂𝒏. 𝒂𝒂𝒏 is available in Japan. 𝒂𝒂𝒏 is a endothelin antagonist, and actually it is dramatically changing to prevent the vasospasm from ROCK kinase. We usually use ROCK kinase inhibitor and nicardipine or something like that, but the 𝒂𝒂𝒏 have the evidence to improve the outcome. Usually many drugs can prevent the vasospasm, but not not good for the outcome. Just to prevent the vasospasm. But this 𝒂𝒂𝒏 endothelin blocker show the improve the vasospasm and also improve the outcome. And then now it's now in Japan, treating the vasospasm was big change. How about the world? So, anyone know about the 𝒂𝒂𝒏? I mean the endothelin antagonist.
Well,
日本
if
と
I
日本
can,
と韓国だけですね、今使えるのは。
if I can comment on this, it's very interesting about 𝒂𝒂𝒏 because I think there was a multi-center study like more than 10 years ago.
2008 or 9.
Yes,
seven,
yes.
7, 8, yeah, around the 7.
But I remember this study didn't find a significant impact of 𝒂𝒂𝒏 on vasospasm. So I'm surprised that in Japan you are using it because to my memory, 𝒂𝒂𝒏 was shown not to have a significant impact. So I don't know if further studies have been performed after that.
Maybe I think it's suitable for Asian people. Maybe, I don't know.
I don't know, but
can be a difference in ethnicity.
Yes, the company really want to expand their the drug, but still very high barrier, I think. Then now it is stopping at at Korea. Japan and Korea, only two countries that use for a moment.
Yes, I remember 2006 or 7. Many experiments, investigators get disappointed by the result of the causal center. But now, 2 years or 3 years ago, in Japan and Korea, made good evidence for the causal center. So now it's dramatically changing in Japan.
Very interesting. Thank you so much. Ashish, did you have a comment?
Oh yeah, we use a lot of milrinone. I think in many centers in India also, we were using then also. It's a phosphodiesterase inhibitor and is being used very, very often in clinical vasospasm. So here we don't treat it like if there's a radiological vasospasm, there's no treatment except for nimodipine. But if there is a clinical deficit on top of nimodipine and the standard management, we add milrinone. The ICU actually is has a low threshold to start milrinone for prevention of vasospasm. I think it is the same as like Fujita in Japan. Like they use it to whatever which can help. I just wanted to add one more thing in terms of I'm seeing a lot of comments and posts by various surgeons on social media where they use a stent in an acutely ruptured situation. So I just wanted to ask if there is any guideline in using a stent-assisted coiling or a stent in a ruptured aneurysm scenario when there is a hemorrhage in the brain already, because again here it is an unwritten code that you do not load the patient on medications or blood thinners like aspirin and clopidogrel when there's already a blood, unless you are treating with a blister. So blister is a different category, but I've often seen MCA, wide-necked MCA, wide-necked PCOM, or a wide-necked ACOM artery treated with stent-assisted coiling, and when the patient presented with a rupture. So and it is becoming a norm. I don't know how ethical that is, but any recommendations in the guidelines or nothing on this regard?
No, there's nothing as such on in the guidelines which is saying about this. It's around 80 or 90 page guidelines which has come out, but they have not said anything about this. But usually, in India also we are doing this. We are treating aneurysms in acute setting also. People are now not afraid of putting in flow diverters in acute settings. So first, what we try to do is when we have got aneurysm in the acute setting, and if we want to do it endovascularly, is try to do it by the assisted coiling techniques rather than putting in a stent. So maybe catheter assisted coiling or balloon assisted coiling. But if it fails and if the loops are coming into the parent artery, then you have nothing but to load with aspirin and deploy a stent.
Or clip it.
We already committed to coiling.
See, this is what happens. But Professor Kato, your thoughts?
No, I think Dr. Hari, he studies a lot of the endovascular treatment in acute stage. Dr. Hari, can you tell about WEB, the new WEB?
Yeah, now we have. Yeah, yes, Professor. Now in India, it's not so common, but we have intrasaccular devices which can be used, which are now currently being used for in acute setting also. So that will prevent the acute phase, and it can tide over the acute phase. So it will help. Maybe in future we can use intrasaccular devices in acute.
I think so. That is mainstream in the future treatment of the SH. I think. Issue?
Yeah, I prefer clipping in any kind of case because I don't have many options. And there is one difference that in India, or I think in developing countries, rather than going by the guidelines, here we give options to the patients that there are two options. endovascular and clipping, and this one is cheaper and this one is expensive. So what do you want to choose? And based on the finances, they decide, because most of the cases they are not financially dependent or insured. So I think the guidelines are at one place, and going by the practical way, most of the world, it's still underdeveloped, and they are going by the options which is available at that place or which they are having. So anyways, it was a very great discussion, and if there are any comments you can have, or otherwise we are now going to close the session.
Yes, issue. Maybe Ashish, do you want to say
just one last thing? Like, whenever
Yeah.
you are practicing vascular surgery, I'll say for young surgeons, always try to practice in a group. Because what happens is, like, if you want to do something, the other person will say, maybe you can clip it, or maybe you can have a different idea. So these are like some checkpoints in your own practice, so that you don't go in a tunnel way and coil everything, or maybe clip everything, as Professor Kato said, without thinking about the outcomes. So in our practice, we have like 4 surgeons, and whenever you are doing something, you can actually, go and have a discussion, and maybe you get an idea from your colleagues that maybe this is better for clipping, don't coil it. So these are the things which I'll encourage everyone to do it, like practice in a group setting so that you can discuss the cases. Thank you.
I totally agree with you on this point.
Yeah, I also agree. Of course, I think we can all agree about this, Ashish. Thank you very much for pointing out. So I think, Ishu, yes, we can close this session and we can move to shortly to the presentation, self-presentation, introduction of the new fellows at the Fujita Bantane Hospital. So I would like to ask the new fellows to very briefly introduce themselves and spend a few words about what they are doing, where they are coming from. So maybe we can start with Dr. Hui. Dr. Hui?
Yeah, could you see my screen now?
Please,
Not yet.
please.
Yes.
Yeah. So my name is Huy Pham. I'm a neurosurgeon from Vietnam, and it's my great pleasure and big opportunity to be a fellow at Fujita Bantane Hospital under mentorship of Professor Dr. Kato. And I come from Vietnam. It's a country in Southeast Asia with the area the same as Germany and Japan. With 100 million people, is a low middle income country, and there's some sightseeing places that are really beautiful that you can visit sometime. I'm now working at Viduc University Hospital. It's located in the capital of Hanoi. This is a biggest surgical hospital in Vietnam with 1,800 beds, and it's a university hospital affiliated with Hanoi Medical University and National University of Vietnam. And our neurosurgical center with 3 departments, neurosurgery, neuro-ICU, and neurology. And there are 30 neurosurgeons in my hospital. We carry out around 6,000 operations per year, and with a focus on brain tumors and vascular diseases and trauma. My education background, I graduated from Hanoi Medical University for the general medicine in 2015. And then I have some internship and neuro residency at the same universities as well. And I finished in 2023. I want to play a dual role of a surgeon scientist. So I also took a Master of Epidemiology at the joint program between the University of Massachusetts in the US and Hanoi Medical University in Vietnam. And I just finished that last year. My clinical interests are interaxial tumors, especially glioma and embryonal tumors. I really want to do research on those topics. But I also want to learn vascular surgery. That's why that I come to Fujita Health Hospital. Endoscopic and brain trauma are also interesting to me as well. So thank you for welcoming me. It's a great pleasure to be here and to know all of you.
Thank you very much, Dr. Hui. Dr. Toivo?
All right. My name is Toivo Ashela. From Namibia. I'm actually not a new fellow anymore. I've introduced myself here before on this platform. So today I don't have slides, but I'm from Namibia, and I am doing a fellowship here at Fujita Health University under the mentorship of Professor Ayako Kato, because of my interest in vascular neurosurgery, which I don't have much exposure of where I practice. Thank you very much.
Thank you, Dr. Toivo. And the last one, Dr. Mayowa.
Yes, thank you. Let me just share my screen. I don't know if you can see my screen yet.
Not yet.
Okay.
You should have a green button at the bottom of the screen.
Yes.
Then share the whole desktop.
Oh, okay. I apologize. I think I just started using Zoom on this computer today. So it's telling me that I won't be able to share. I have to quit Zoom and restart again. So if you don't mind, I can just say what I would have loved to present.
Sure. Go ahead.
Okay, thank you. So my name is Oluwamayowa Opara. A Nigerian. I'm one of the 6 female Nigerian neurosurgeons that we have. I'm currently the co-chair of the Young Nigerian Neurosurgeons Forum and secretary of the Young African Neurosurgeons Forum. I'm still a very young neurosurgeon. I'm a member of various committees and currently co-editor of the WFNS newsletter. I come from Nigeria, which is the 6th most populous country in the world. The last estimate was about 230 million people. It's multilingual and multi-ethnic. And unlike Vietnam, as at April 2024, we have a total of 161 neurosurgeons. Of that, 6 of us are females. I currently work as a consultant neurosurgeon at the Imo State Specialist Hospital, Owerri, which is in southeastern Nigeria. I also visit the Federal Teaching Hospital, Owerri, also in Imo State, and the Federal Medical Center, Umuahia, which is in Abia State. These 2 states are neighboring states. And between the 2 states, they cover about 5 to 6 million people. I currently do basic general neurosurgery and spine. Most of the cases I do are spine cases because I work with a spine surgeon. However, I see quite a lot of vascular cases, and I have developed interest in vascular neurosurgery right from my training days when I was a resident in Usmanu Danfodio University, Sokoto, and when I spent some time in Cape Town, I developed interest in vascular neurosurgery, and that is why I'm here under the tutelage of Professor Yuko Kato. I've spent just about 10 days here, and it has been a wonderful experience so far. Quite a lot of vascular cases here, both endovascular and microsurgical. I actually didn't know that they do a lot of endovascular here before coming, but I'm glad to find that they do that here, and I'm interested in both. I really want to develop my skills in clipping aneurysms, and I'll be grateful to have that before I leave. Thank you.
Thank you very much for these self-introductions. It's always very nice to meet the new fellows in Bantane Hospital. And before closing completely the session, I would like to ask Dr. Hari to make an announcement about the newsletter, actually.
Hello. Hi. Very nice to meet the new fellows. Very nice to see new experiences from Japan. So last year, we also started a new initiative from Fujita Bantan Hospital. We also started a newsletter, which is starting to come from every 3 months from last year. So let me share my screen, just a few brief words about the newsletter. Can you see my screen?
Yes, we can.
So this is the newsletter which we started last year. Already we have published 2 editions. This left side is the first one, right side is the current edition. So in this newsletter, we are aiming to give insights about the current Fujita environment and current activities from the association. So, and we also give the fellows insight and the fellows point of view. And we also provide what our association is doing from the academic point of view. Like we have been conducting webinars every monthly. And we also give the future announcements. So this is the overview of the newsletter. So I just wanted to ask for some extra help from the current Fujita fellows to help me in the newsletter to give the more updates from the field, because we are away from the Japan. Since you are all in Japan, so if you give regular updates, so it will be helpful for the newsletter, and we can improve a lot more than this. So I ask current fellows, Dr. Opara, Dr. Yu, and Dr. Taiwo to help me in this, and I can always be under assistance or give you feedback. And
so maybe Hari, maybe you can write to them, please.
Yeah,
Some
yes.
instruction and
Yeah.
or a deadline or whatever you want from them. You see.
Yes.
Yeah.
Thank you.
Thank you, Ari, for this announcement. And of course, anyone who wants to help in this newsletter, but also in organizing the webinars will be very welcomed. And I would like now to thank both speakers today, discussants, and the commentator, Ashish Kumar. Of course, my co-moderator, Ishu Bishnoi, and I would like to ask Professor Kato to give a few words to conclude this webinar.
Yes, thank you very much. We have very good discussion with the 2 brilliant speakers. Especially, I think, Charandeep, that you made a good summary of the big papers. Thank you so much. I think we learned a lot from your talk, I think. Of course, Sensei, thank you very much for your great long historical your experiences. Do you have such kind of model, 3D model? Can we buy or drilling?
Yes, the model is available from the Japan Medical Company. Japan Medical was probably Ono Kogyo. It's available now.
Okay, so cavernous sinus model, maybe, or
Yes.
temporal bone. Yeah.
Yes, we can practice about anterior craniodectomy and the transcavernous approach, and also the anterior petrosal approach.
Okay, so maybe you can show us your good video, the demonstrative video, please.
Yeah.
So I thank you so much, everybody. I think we had a very great time. Maybe more than two hours, I think. Thank you so much. See you next time. Maybe Albert.
Thank you. Thank you, Professor. Thank you, everyone. And see you next month for the next webinar.
Thank you.
Good day and good night.
Thank you.
Bye-bye.
Bye.
Thank you.